such an honor to be back here with all of you today. It's been about 15 years since I graduated from country school. This place still feels a lot like home. I still remember actually reciting poetry on this stage, playing soccer out in those fields, all of our incredible class trips. You know, it's, but the best memory of all is actually this picture right here, class 2003. I always think back how incredible it was back then that such a different group of people, all these unique individuals, could come together and function so well as one unit. I think it's certainly a testament to the 31 individuals you see here in this picture, but certainly a lot of other folks behind the scenes who are not in this picture. Parents, teachers, neighbors, babysitters, aunts, uncles, coaches, you name it. A lot of other people working together to help us realize our potential. You know, they were there to support us when we needed comfort, challenge us when we needed motivation. They were there with us every step along the way. And it took a village to raise these children. That's a lesson that I took with me after I left the country school. This notion that wherever I was, whatever I was doing, I was never really alone. I had my village to help guide me. So admittedly, it took me some time to realize as well that this notion of having a village is really a privilege and not necessarily the norm. And that moment actually happened to me in the spring of 2014. So let's flash forward to the spring of 2014. I was 24 years old, fresh out of college, had a molecular biology degree, and I was working in cancer research. But there was a part of me that wanted to get out of my comfort zone, do something a little bit different, and work more directly with people. And so I became a community health worker. I started spending my time in shelters, pantries, churches, needle exchanges, mobile health clinics, really in those touch points out on the streets of Boston, where I'm from, serving those in need. And it was in the spring of 2014, at a mobile health clinic in East Boston, that I met Huey. So every Thursday night in May of 2014 onwards, I started working with this mobile health clinic. Provide food, toiletries, clothing, just kind of, you know, someone to talk to for a lot of people out there on the streets of East Boston that are just trying to get by. But a handful of them looked like Huey. When I first met Huey, he was 56 years old, homeless, sitting on a bench drinking Listerine, which I later learned is 21% alcohol. He was also wearing a green hospital gown because he'd just come back from the emergency department at Boston Medical Center. And it turns out he goes there 4 to 5 times a week. So every Thursday night for about 6 months, I was working in this mobile health clinic. I'd see Huey kind of going through his vicious cycle, unable to navigate his way through the system, kind of helpless. And then one evening he passed me in the parking lot. And I think there was a moment for me when I realized that there are people like this at all these different community-based organizations I was going to. There's vulnerability wherever I went, but a handful of them looked like Huey, kind of caught in this vicious cycle, unable to make their way through. I started learning a bit more about this space. And the Hueys in the system, these vulnerable individuals in the healthcare system, they're known as the superutilizers. 5% of patients drive 50% of cost. And they're predominantly affected by socioeconomic risk factors like homelessness, food poverty, substance abuse, and general lack of support. And increasingly, they go to community-based organizations like the shelters, pantries, churches, mobile health clinics as their touch points for survival. And I started to see that. The paradigm shift that we're seeing in the healthcare system is that whereas access to care is not really guaranteed, the community-based organizations have kind of become these new gateways into the healthcare system. But one of the things that really astonished me, in addition to the vulnerability at the front line that the organizations are seeing, is that a lot of them are under-resourced nonprofits. They're often using pen and paper, sometimes nothing at all for record keeping and data reporting. As such, they're under-reporting data, being underfunded. They spend a lot of their time doing record keeping rather than delivering care to the members that they'd like to serve. It's a vicious cycle for them too. And so, in the fall of 2014, after spending a few months at the front lines as a community health worker, I reached into my village, you know, the folks that surround me in Boston. And fortunately, I found some software engineers. And we started talking about what can we do to address the needs of the front line, these community-based organizations that are struggling with record keeping and data reporting, but along the way, try to better connect people to care. And so in the fall of 2014, that evolved into Boswell, the digital health platform that I've been working on since then. So at a high level, what we're doing is we're building a bridge between community-based organizations that are serving those really vulnerable populations and the payers and providers that are taking on the risk and accountability to serve these populations, but often lack the window into the community to better deliver care. And so what we do at a high level is we provide free software to community-based organizations. It's a free web-based application. If you go to boswell.io, boswell.io, you can find us. The community-based organizations that are currently using our platform, they have customized intake forms that helps them better report data, do intake of the clients they serve. But along the way, they're building longitudinal profiles on individuals, many of whom are like Huey, who are otherwise off the grid and invisible to the healthcare system. And the model from there is that we want to build a hub-and-spoke model where the conventional medical home, which is thought about as the four walls of the clinic, we can extend that beyond and into the community where these community-based organizations are. And really kind of build a system of bidirectional communication between social workers at community-based organizations that are serving vulnerable individuals and care coordinators at health plans and health systems that are trying to reach those individuals. But this is just the tip of the iceberg. You know, when I think about Huey, when I think about all the individuals that I've seen at these different community-based organizations out at the front line, it's not an overnight process for them to end up where they were. You know, Huey had homelessness, he had food poverty, he had substance abuse, he had a general lack of support. And those are things that were occurring before he had a healthcare issue. It's the healthcare that did him in. But all these other issues upstream could have been addressed earlier. And so I ask all of you, you know, how can we work together collectively, recognizing that, you know, we've been fortunate to have this village, to have all these resources, to have this kind of support, but start contributing to other places where there's vacuums, where there are gaps, where there's that lack of support. You know, how can we work together and address some of these systems level problems that are affecting a lot of population individuals every single day, and really innovate where there's a need. And so that's kind of what we started to do with Boswell. It's still an early stage endeavor. We're hoping to continue to build up our evidence base and pilot this in the coming months and years. But I think there's a lot of opportunity out there, a lot of different verticals to pursue, a lot of different aspects that are gaps that can be filled in the system. But it takes a village. It takes all of our work. It doesn't happen overnight. But I'm confident that if we work together collectively, we have an opportunity to make some of these changes. Thank you so much.